So, Corrado, the floor is yours.
Thank you, Mark. Do you see my screen?
Yes, very well.
Okay, so you still see it now?
Yes.
Okay. All right. So hello, everyone, and thank you for the presentation, of course. And so my goal today is to introduce you to the first tier of the risk assessment, or risk analysis, something that we have to clarify right now. Now, if we go back a little bit, and then we go to the 80s or 90s, where the WHO put together some information concerning the paradigm of the risk analysis. And you see that the hazard identification is just one of the sub part of the risk assessment. Because for the risk assessment, you have to deal with the hazard identification. Then you have to look for the dose response, and then altogether with the exposure, you can characterize the risk. And you see that risk analysis is composed of three different boxes: risk assessment, risk management, and risk communication. That is something that we will not discuss today. So at the beginning, as I said, you have to start to identify the hazard and to identify dose response. Why? Because your job is, doesn't work, right? Doesn't work. Okay. Your job is to derive a point of departure. What is the point of departure? What is the, the trace that you have to follow, the path that you have to follow to arrive to derive a point of departure? Because the point of departure are not calculated, are derived from line of evidences. The line of evidences is very easy, because line of evidences is everything, all information that you can collect from the open literature or from unpublished reports available. And then, so when you put together your line of evidences, and then can you mute your microphone, please?
Please mute your microphone, please.
Okay, so then you put together all the line of evidences that are just scientific information. Then you arrive to derive your point of departure, which are, mainly are the no-YEL and the benchmark dose, the no observed effect, adverse effect level. So both are just, what we call point of departures. Now, let's again try to define what is, the difference between the no-YEL and the benchmark dose. It's not so different, because, as far as the no-YEL, it's something that, it's something that you choose when you draw your design of your experiment, because you see that, when you design your experiment, you decide some doses. And then, as far as the no-YEL, at the end of the experiment, you have to look for the doses, the highest dose, which will not produce any toxic effect. And in this case, you see that your dose response curve will end up with a no-YEL of 10 milligrams per kilo body weight. When you deal with the benchmark dose, it's something more complete, I would say, because, complete because you look, you analyze all the dose response curve. And then, so once you get to the confidence intervals, the lower and the higher, then so you take, the lower confidence level, and then the mathematical approach will allow you to derive the benchmark dose. In this case is the lowest benchmark dose, because you use the lower interval, the confidence interval. And then you see that the difference is not so big, but the problem that sometimes the selection of the derivation of your dose is more precise, because sometimes it's between two of the experimental points the doses that you have decided. Now, going ahead, now you have your line of evidences, and then the international guidelines will ask you to weight of the evidence, this line of evidences. Means that, I mean, you have to put together all the line of evidence and then try on the basis of the quality, on the basis of, you know, different parameters that are present in the guidelines. You have to weight all the evidence of the line of the evidence, and then you start what sometimes we can call a art approach, because you know, putting together the line of evidence is a kind of a job. Then you see what now happens is okay, that you have these small pieces, and then you start to put together the pieces until at the end you can get an overall picture of the you know, your assessment. When I say overall picture, yeah, just I mean to tell you that I mean, don't stop to just one line of evidence result, because what is important in the hazard assessment is you know, the overall assessment. So you have to weight all the line of evidence put together, try to find a consistency among all the line of evidence in defining again what I mean we observed, you know, the point of departure. Now, point of departure is something that then because the, you know, the path is long. Because yeah, point of departure, and then what is the use of the point of departure? Because point of departure are derived from experimental data, from in vivo, in vitro, whatever. We shall see in shortly what I'm meaning. So when you have defined your point of departure, then so a further step is try to identify the safe dose for the population, for animals or for whatever. I mean, then so you have to translate the point of departures in health-based guidance values, which are, you know, different, because we started with the admissible daily intake, and then and now we have the acceptable daily intake when we deal with intentional chemicals added to the diet or added to an environment. Then we call the tolerable daily or weekly intake for the contaminants, and then we have the margin of safety for cosmetics that permitted the exposure for drugs, and so you see that in the slide there are two big boxes: the non-DNA reactive carcinogens and DNA reactive carcinogens. Why the difference? Because you know, in the hazard assessment, you reach a point where, I mean, you have to decide what is you know, the solution. So you have to deal with non-DNA reactive carcinogens or toxicants in general, or with DNA reactive carcinogens, because you know, with the non-DNA reactive carcinogens, you have a threshold. You can define a threshold. You can define a safe dose. That is not possible, or I mean, not scientifically, but for the policy of some agencies, that is not possible for some genotoxic and carcinogen chemicals, where you cannot define a precise dose, but you can try to score the potency of your carcinogen, genotoxic carcinogens, and then try to create a kind of a list of concern. So on the top, you will have the most potent genotoxic carcinogens, and then so you can use the concept of marginal exposure, because I mean, you can define what is the distance, if you want, what is the margin of exposure between the lowest, we say the lowest benchmark dose concerning the incidence of cancer in the experimental animals. And then, so once you compare the lowest benchmark dose as far as carcinogenicity with the exposure, then if you have a very wide distance, range, so then the concern is less. But don't take the margin of exposure as a safe dose. It's just a concerning approach. TTC is, the threshold toxicology concern is a bit different, but again, it's a tool, to define, in some sense, to anticipate, because TTC is something that you use on the basis of a chemical approach. That is something that we will discuss. Now, what is new is that nowadays, since the use of animals is very criticized, then the attention of the scientists and toxicologists is toward and something that is more wide. So is what is called the integrated approaches to testing and assessment, the IATA. And then as far as the IATA, you see this slide, I took from internet, this slide, where, it's very clear that, you have to collect, to gather, a lot of information coming from whatever, from all the sources that are able to give you some information, some line of evidence is able, to arrive to identify the hazard or your chemical. Now, in the IATA approach, we introduced the new approach methodologies, and of course, beside in vivo, because if you have some in vivo results, so you have to consider them, and then so we can have results in vitro, ex vivo, in chemical, because it's quite interesting to understand what is the reactivity of your atoms all together in a molecule. The in silico prediction using computational approaches, read across, predicting endpoint information for one substance by using data from the same endpoint from other substances already studied very well. So, and then you put together, all the information, the vivo and all the new, the NAMA methodologies, and then you are able, to extrapolate, some of the results from in vitro to in vivo in it. Now, let me jump just for a second to the next concept, is the risk. Because once you had the hazard, then you had to define the exposure. Because as for the margin of exposure, I just anticipated that, there is a kind of ratio or distance or range between the lowest carcinogenicity dose and the exposure. But the exposure is something that is not easy as it appears, because you see that we cannot consider just the exposure from one source. So we had to start to use the integrate risk assessment. So then you had to not only to know what is the dose of toxicant, but you should have some information also on the individual's exposure and a special population group. So children, babies, aged people, or pregnant women. And then another problem is that, what is the exposure is intermittent, because maybe it's not, is once a day, once a week, once a month, so you don't know. So that's why the exposure models are a little bit complicated, because you need, some time to work, try to understand, these probabilistic methods and to apply them, on the basis of what are the results that you are in your hands. Now, and then, just, to arrive to the end of our path is, as I anticipate, the end is the risk characterization. So where, you have your health-based guidance values, then in milligram per kilo body weight, you have the exposure in milligram per kilo body weight, and then what is the, what you have to judge, if that the safe dose should be, much higher than what is the exposure the aggregate exposure. And that will be the end of the story. But I mean, I hope that the concept of the hazard is quite clear in your mind now. Now, if we try to detail a little bit more what we have said, we have to start, to respond to what I say, simple questions. So the first one is, what chemical were we exposed to? Because, we toxicologists have to understand that alone we cannot do everything. So that's why sometimes our chemist colleagues are very, very important, because they have to show us if our material, that is what we are testing, is the specification is adequate. Because, for instance, you see, degree of purity. Degree of purity means that maybe sometime what you have is that your material is 95%, but sometime for some azo dyes, for instance, the 5% of the impurity was the reason of the carcinogenicity of the dye. So that's why to know to characterize your material is so important, because from the chemistry, sometimes you can understand very much what maybe will happen in the next future. Then the manufacturing process and also the physiochemical properties, because on the basis of pH, your chemical can be irritant or not, or maybe if the partition coefficient is high, then you can anticipate that you can have some bioaccumulation, or if your chemical tend to enter in the environment very easily, having a high vapor pressure, then so it can be a problem for your lungs. So that's why you need really a good help, a good from your chemist colleagues. Now, other questions are, for instance, they cause toxicity, and not only because of the pharmacodynamic properties of your chemical, but you have to know that there is a target, essentially, because the first thing to understand if from the ADME properties, your chemical is absorbed, is metabolized, and then it is distributed and excreted. See, these information are very, very important, because if you have very good information from the ADME, then so you can anticipate again what can happen in the body, because absorption is something that is very important, because if your chemical is not absorbed, then systemically is very difficult, can produce some toxicity. And then if your chemical is metabolized, and then I would tell you that 80% of the time the toxicity is given by a metabolite. So that's why one thing that you have to clarify is that you should understand much better what is the internal dose, because the external dose is what you give to the system, to the experimental system. But then it's not said that the parent compound is the toxic chemical, because it might be a metabolite, and as I said, most of the time is a metabolite, and then that's why the pharmacodynamic can help you to understand what might be the internal dose, because the internal dose is the dose of the toxic stressors, because is that you are interested in, because that is something that you have to take in consideration when you calculate your health-based guidance values. Now, another question is what are the mechanisms of toxicity? That is a very important concept, because when you extrapolate some results from experimental data from animals to humans, so it's quite important to know if the mechanism of toxicity is similar, because otherwise, I mean, you are extrapolating something that is wrong. Now, concerning the mode of action, I mean, the most important parameter is the causality. Remember that, because the causality and the dose response curve are the most important parameters that you have to deal with. And concerning the causality, nowadays we have very good tools, because the mode of action. So we have, you see that for the molecular initiating event to the organ system. So we have the adverse outcome pathway, which is quite good to help us in defining the mode of action. That again, the causality, because the adverse outcome pathway is something that becomes very important when all the key events are very proved. Now you remember that. Coming back to the hazard, I mean, there is a certain point in the evaluation where, I mean, you had to decide, I mean, on the basis of the data, of course, if you are dealing with something that a non-DNA-reactive carcinogen or a DNA-reactive carcinogen. Because as I said, the situation is quite difficult, because in some part of the world, I mean, where the DNA-reactive carcinogens or genotoxic and carcinogens, so they are treated in a different way, because usually I would say that the agreement is that genotoxic carcinogens, they do not have a threshold, and that is quite different if you have non-DNA-reactive carcinogens or toxicants in general. Because for the epigenetic carcinogens that are acting as, not they are carcinogens, not through DNA mechanism. So then, the guidelines will indicate that you can admit a threshold. So then, in that case, you can calculate a point of departure, with able to derive then a safe dose. That is not possible for the DNA-reactive carcinogen. Now, here, very quickly, there are 4 solutions for the hazard characterization of genotoxic carcinogens. The first one is ALARA. It's not very much used, because it's just a hazard approach. It's not very useful. Then the major are, the cancer stick estimation based on the linear low dose extrapolation, where you calculate, the 1 to the -6 incidence of tumors in the population. And then the alternative is what I anticipate is marginal exposure. And here we have a number, you see absolute number, which is 10,000. So what is below 10,000, is of concern, depending, of course, how is the number. And above 10,000, the concern is less and less and less. Threshold toxicology concern, for genotoxic, for chemical containing some structural alert for genotoxicity. So then the system will allow you to use as a threshold 0.15 microgram a day. And then if you are dealing with toxicants or not DNA reacting chemicals, then you can use the 3 Kramer class, or maybe 2, because mainly the first one and the third one. So these are some solutions. Another question is, who is susceptible? Because this is a very complicated question, because it depends from the genetic, from the genome of people. Because, for instance, the allergy sensitization is something that it doesn't depend from a specific dose, an average dose among the population. Sometimes, so when we deal with the genetic polymorphism, so means the difference in the genome of individuals in a population, so then you use another concept. You see that, you see that this axis, you have the frequency of the phenomenon that is maybe cancer, allergy, or whatever, and then in the axis, this lower axis, you have the concentration, the dose, but here is the frequency. Is not the incidence of the effect. Now, what happens here is that there is a part of the population when you increase the dose, and then the frequency of the phenomenon will increase. Then you have the average of the population where the increase of the dose will not increase the appearance and incidence of the phenomenon. And paradoxically, then you have a part of the population which is less sensitive. So then if you increase the dose, then the phenomenon will not appear as was in the first part. So that's why, because our genome is different. And so some enzyme, for instance, for the families of P450 or GSH or whatever, so they have some very small difference, but these small difference can produce enzymes which are not so, they are not, the activity of which is not the same among people in a big population. And so that's why toxicity, the phenomenon, the result, it will be different among people. Now, but the most important part with the causality, I already anticipate, is the dose response. The dose response is not because just we know very well that if you increase the dose, then you increase the biological event. But you see, what is appearing here is important. It's not the dose response per se, but the dose response for toxicologists is important, because so we have to arrive to define the toxic effect. And then we have to come back and look for the threshold, because that is, what our aim. Our aim is, to to measure a toxic effect, to be able to going down to see a threshold, and more we go down, then maybe we can arrive to the no yellow, the point of departure. So what we need is not a dose response per se, but first we had to design a dose response curve for a toxic effect. For instance, here I put some enzyme induction in the liver, and then we are asked to produce another dose response curve that is backward, if you want, in some way, to define the point of departure, the no yellow or the benchmark dose. And that is, our aim, as I said during our first part of the presentation, on to derive a hazard, to identify a hazard, so a point of departure. But then very quickly, what we need is to know what is the margin of safety between the toxic dose and the no effect dose. So let me just the dose response curve. I'm not so precise to explain the concept that I am trying to give you, but try to get the message from this slide. Then if you have your point of departure, so then point of departure, we say that generally is taken on the basis of one experiment in the animals with different doses, and maybe the time as 90 days, or maybe for the carcinogenicity, even 2 years of treatment of the animals with many doses, or many 2 or 3 doses, and of course a control group. I mean, to compare. I mean, if you have an effect after the administration of your chemical, then so you start from your yellow benchmark dose, and then so from the animals, I mean, you use what is called a safety factor or uncertainty factor. It depends where you live, and then the first factor is interspecies. So you divide your value of your point of departure by 10, and then so you divide it by another 10 your point of departure because of interspecies, because of the polymorphisms, because we said that the genome among the population is quite different. So then for the sake of safety, then you apply 2 safety factors. Don't take this number as just invented, because here you can have 1.8 or 2.5 or whatever. The concept is that you divide it by 10 first time, and then you divide by another 10, and you get what head-based guidance values, the admissible daily intake or the tolerable daily intake or whatever it is. Now, very easy. But I mean, our problem, or at least my problem, when we talk about, toxicity, and then what is the message that, we have to convey? Because, I mean, if we convey the message of hazard, it's very, very difficult. It's very different than, I mean, talk about the risk. Because, the hazard is always a probability of a chemical to cause toxicity, and the risk is what? Is again a probability of chemical to cause toxicity in humans, because as far as the hazard, you define a kind of intrinsic potency of a chemical, but it doesn't have anything to do with the risk, because when you discuss the risk, you must have also the exposure, because otherwise you cannot face the problem with the risk. Because of course, I mean, if you have a bottle of I don't know, a carcinogen, benzene on your table, but it's closed, then the hazard is very high, the risk is 0. But if you open the cap, and then so some of the benzene will enter in the atmosphere, and so you can breathe some of the benzene, then the risk starts to increase. So hazard is the intrinsic potency of a chemical. Risk is the possibility to produce a harmful effect in humans, depending on the dose. So we have to go back to Paracelsus, I mean, to learn the lesson. But I mean, the media today, they prefer to use the hazard, because hazard is more pushing, it's more sells much more, because say that is toxic, not it's toxic if the dose can be above the threshold. No, toxic is toxic, and that's all. That is not correct. Now, what the problem is also from some guidelines from some agencies where they reason on the basis of the hazard, and they classify chemicals on the basis of the hazard. See that the GSH and the CLP regulation of from the ECHA, from the European Chemical Agency, is something that will not help the toxicologists, because they classify chemicals on the basis of the hazard. And so when you classify the chemicals on the basis of the pure hazard, you see this table. You have just very briefly. As far as the acute toxicity, so you have them oral, dermal, and gases, but we take oral. Then, I mean, if you try to measure the acute toxicity, so one administration and 14 days, 14 days waiting, if the animals will die or not. Now we have different, not this is the oldest one, but now we have a different situation where the animals are not so many. But the idea is to reach a number. And then if the number, the milligram per kilo body weight are in the range of 2,500 as per the LD50, then is category 5, or 300, 2,004, 350, and so on. So all the chemicals are classified. But that is something that can help, because maybe can help if you have an accident somewhere, and then you have boxes and bottles around on the street, and then so you look for the label, for the symbol, you look for the category, and then it will help to tell you that what you are looking at is something that can be very dangerous or not, but it will not tell you the real risk. It will not just, it will really inform you just concerning the pure hazard. That is, can help, but is not the message that we would like to convey. Now, the same is for carcinogens. You see that in Europe we have these 3 categories, 3 because in category 1 is 1A, 1B, and category 1 is known, and B presumed, category 2 is suspected, and then again, so the chemicals are labeled with 1A, 1B, 2, and that is something that can lead to a further classification if you have, for instance, mixture. Because if you have, your mixture, an ingredient classified 1A, 1B, then so you have to classify your mixture in 1A, 1B if the percentage of your ingredient is more than 0.1%. If it's a carcinogen 2, then so the concentration of your ingredient in the mixture should be less than 1%. Now, let me finish to show you a few slides on the some of the hazard parameters that I like to consider as far as I had to identify hazard. One important part is the route of exposure, because sometimes some people we use for the hazard assessment subcutaneously or IV results, but that's okay. But you have to consider how the bioavailability is quite different. You see here in this graphic what is the the bioavailability of chemicals through different routes. You see intravenous, you have a very quick absorption and very quick excretion. Inhalation, you have a different absorption and inhalation, gastrointestinal, dermal. So that is something that one has to consider. Time of exposure, very easy. The example of the pregnancy, where you have 3 different periods where the gravity of the effects is very clear. More during the organogenic period, that is in the first weeks of the pregnancy. Reversibility. Let me finish with a couple of slides, just to show how chemistry can help, because you see that your toxic elements, parent or metabolites, so they should have some very clear properties to be electrophilic, for instance, chemical, to have the potential to react, to share some electrons with some atoms like nitrogen and oxygen present in all our macromolecule. And of course, if you have interaction with those atoms present in protein, polysaccharide, RNA, so you can have cytotoxicity. But if your chemical enter in the cytoplasm, arrive to the nucleus and interact with DNA, you can have a mutation. But that's not the end of the story, because I mean, you can have a repair. You know that every day we have thousands, 10,000s of repair in our cells. And that's what will save us from irreversible reaction. Now, when we talk about irreversibility, then you see that in this slide we have that our chemicals that we call alkylating agent. They are not just methylating and ethylating, but alkylating means that they are very electrophilic compound. And then, so they can react with our macromolecule. And then, I mean, you have to understand that it's true that, I mean, if they react with DNA, RNA, we have a big problem with our somatic or germinal cell. But don't, I mean, remember that even when you have a covalent bond with the proteins, then you can have sensitization, of course, but be careful, because I mean, you can have a complex between your protein and molecule, your protein and your molecule, and then can lead to the cellular necrosis. And then, you know, if this necrosis is chronic, for instance, the necrosis will lead to inflammation. We know that it's not apoptosis. Then the chronic inflammation can lead to a very, very important production, for instance, of radical oxygen radical species, or whatever, or maybe can induce the cell replication in a way that cell replication is so fast that I mean you cannot repair, I mean, some of the errors that can raise from this very fast cell replication. Now, I think that I had another example, like the endocrine disruptors, but I mean, we can discuss it if we have some questions to pose. Thank you very much.
Thank you very much, Corrado, for this very nice and very complete presentation. I mean, you cover basically everything we should know to understand for risk assessment or organic toxicology. So we have some questions. We have one question in the chat. So I'm going to read this question. Could you please give information about using IATA approaches in risk assessment?
It's a good question, of course. The IATA, I can give you my experience, because I am quite involved in the risk assessment or safety assessment of ingredient or cosmetic products. And probably you know that from 2013, I mean, we cannot use anymore the in vivo data. That's why there is a big effort, I mean, to enter in the NAMS and the IATA, of course. So far, I would say that, I mean, there are very good elements concerning the local toxicity. So irritation, eye, skin, and sensitization, but not very much concerning, carcinogenicity, immunogenicity, and developmental and fertility, and so on. That's why, I mean, there is a lot of effort to develop new tests, but so far, I'm afraid that, we are still waiting for good solutions.
Okay, so to continue on this question, so do you think that the new approach methodologies, the NAMS, are clearly right now it's really too early to really use them in a risk assessment? Because we can see in a chemical allergy or sensitization now many effort to try to do some risk assessment using combination of NAMs and so what is your opinion about that?
I think that, I mean, you use the right word, combination. So, I mean, the NAMs, you know, the importance of the NAMs are that, I mean, you have to weight the evidence of the NAMs. So the importance is that you can use data from, you know, the chemical approach, from the QSR, from the Red Cross, from in vitro. But every time you have to, as I said, I hope several times, to put together the line of evidences and try to weigh the evidence. Because, I mean, at the end, you have to have something very consistent. Because if all the you know, tests, all these tests, we give you different response, be careful because you can reach a very, very dangerous conclusion.
Okay, thank you. So I've got another question in the chat. So thank you very much for this excellent presentation. Could you please come back to the cocktail effect of cumulative chemicals, like in the mix of chemicals?
I'm afraid that I mean, I cannot offer you solutions because I think that there are very good attempts from the EPA, from the Food and Drug Administration, from the EFSA, from ECHA, you know, from all the agencies. But I believe also EUROTOX produced a good document. There are many documents, but again, I think that if I tell you, if we continue to, I mean, not avoid, I mean, to go in depth in the mode of action, but I mean, the AOP is a good solution, of course. Then, so we cannot solve the problem just with the, you know, each of the NAMs. So when we talk about a mixture, I mean, we know that, I mean, there were very famous experiments in the past where, I mean, were done on some mixtures, and the results show that if the components in the mixture were all below the NOAEL for each individual chemical, I mean, you know, you didn't have any problem. Once, I mean, in the mixture, you have chemicals present in the high amount, high doses than the NOAEL, then so you can get some problem. So again, you see, the problem to say that, I mean, you have to sum up the results, or, I mean, you have to look at the mode of action and try to look at the potency. You know, there is something that is very good, but there are not so many examples yet.
Okay. So I've got another question. Okay, there's two questions. Could you please precise the different approaches, or your preferred approach for the risk assessment of substances with endocrine disruptors effect or suspected?
Let me go back to, you know, the problem of endocrine, you know, is that, I mean, there is a big discussion around Europe now concerning, you know, if we will admit a threshold or not. That is a very important question, because it seems that the idea in Europe is to go toward the no threshold effect. And the idea is that if you have, you know, a hormonal an effect concerning, you know, the hormonal effect, then so you have to discard the chemical. That is something I mean, I don't agree on that, I'm sorry, because especially for the you know, endocrine effects, I mean, you have not, you know, the difficulty is that hormones is a very, very bad example, because I mean, when you deal with hormones, you know, the doses or the effects are, appearing and disappearing depending on, the period of the life or the sex or whatever. So it's not easy. And that's why maybe the regulation will, consider any endocrine effect as, something that should be avoided. And that is the idea, that to consider, to classify the endocrine effect as a cutoff as far as the use or not use of a chemical. But you see, that is in contrast with some of the regulation where, the two important things is that, you should have a relevance for humans. And that's something that sometimes is not considered, because once maybe sometimes you have an effect on some cell preparations, but for some people is all right, proved that you have a endocrine effect. When we know that some cells they have estrogen, androgen, and whatever oh my goodness, on the cell membrane you have places. I don't remember now. Okay, they will interact with androgen, estrogens, so receptors. Sorry. So some of the cells has many receptors. So then it will be difficult to say that it's an estrogen or androgen or whatever has a thyroid effect. So it's a very complex problem that should not be close the basis of a cutoff concept.
So I've got three more questions. So one more question for the same person about sensitizer effect. Few OECD, progress on methodology for inhalation testing. And so what would be your recommendation, preferred approach?
Sorry, what you say? What is the I didn't get the target.
Okay, it's about sensitizer effect. Few OECD progress on methodology for inhalation testing. So what would be your recommendation?
I think that we are even more far from the solution than from the skin.
Okay. So
it's something that again is in discussion. But as far as the skin, I think that the solution is not so far. But for the inhalation, I believe that you still have a lot of work to do.
Yeah, I could complete because it is my field of expertise, and I would say I fully agree with you, Corrado, that for sensitization, so the inhalation route, we are very, very far, especially that people probably get sensitized by the skin and then get sick by the respiratory route.
Yeah.
So another question, it's very specific. Have you had to assess coumarin compounds in endocrine effects? What was your approach?
The coumarin.
The coumarin and endocrine effect.
Coumarin endocrine effect. No, I don't have experience on that.
Okay.
But coumarin are drugs. No.
So, and another question. So you talked about hazard characterization for genotoxic carcinogens. What about non-genotoxic carcinogens? Is it more challenging? Can you use the weight of evidence approach?
Good question, because I sometimes tell to my students that I fear more non-genotoxic carcinogens than genotoxic carcinogens, because with genotoxic carcinogens, you have a flag of genotoxicity. Then you can reason the repair and so on. But we have some epigenetic carcinogen, which the mode of action is can be quite different, because as I said at the end of my presentation, so you can have if you have inflammation, a chronic inflammation, for instance, in your gut or whatever, this chronic inflammation can proceed to produce maybe neoplasia, because as I said, the reasons are very clear, because I mean, in the inflammation, you have a cell replication, very, very fast cell replication. And then if you have a fast cell replication, then you have not the phase of the cell replication so long to allow, for instance, P53 to repair the damage. Or during the inflammation, you have a production of reactive oxygen, nitrogen species in a quantity which are, important, I mean, to produce maybe a genotoxic effect now. And then if the genotoxic effect is not repaired, then so everything can proceed to the formation of neoplasia. So it's kind of hidden phenomenon. That's why you cannot anticipate. I mean, you can say, yeah, a hormonal effect. If you have a substance which can induce the cytoplasmic receptor for estrogen, for instance, of course, that potential can be an epigenetic carcinogen. But so far, I believe that, again, we have to study more.
Okay. So I think we are arriving at the end because it's 1 p.m. I've got no more question in the chat. So there is no more question? No? Okay. So again, thank you very, very much, Corrado, for his excellent presentation and this excellent overview. It's really start well the webinar series. So the one question, will we receive access to the recording? So Elaine, I think we will have access to the recording through the EUROTOX website, I remember, huh? Elaine, yes?
Yes.
Okay, so that's perfect. And so thank you very much to everyone for attending, and see you maybe at next month, that we have David Jones, April 19, same hour, on why COVID vaccine has been developed so rapidly. Thank you very much. Have a very nice day. Bye-bye. Thank you very much again, Corrado.